legacy activities, which often include a spiritual component. We talk about mortality and prognosis. So there's not a lot of wiggle room, for the eyes, ears, and, mouth closed. You really have to be ready in many ways. And sometimes it's surprising. Like sometimes we'll admit a patient to hospice, and in the hospital they've been a full code, and we're having a conversation now about whether or not resuscitation efforts make sense and are congruent with their goals, and the patient is literally never considered, right, whether or not resuscitation is appropriate for them. It's just kind of a given. Like, what do you mean you would just not do anything if I died? And so then we have to like back the truck up and do a lot of prognostic education. What do you know and understand about your diagnosis and about the medical landscape ahead of you? Even if they sign on to hospice, they're often seen in the making of the care plan and addressing patients and families' needs, which may like pop up out of nowhere, have to be alert. The other thing I want to just mention that's not on the slide that's probably useful for you to know is a lot of people don't understand that when we say we cover everything, what we mean is we cover everything that's related to the hospice diagnosis. So for instance, if I have a patient come on with lung cancer, okay, and they also have coronary artery disease and hypertension and hyperlipidemia and COPD. Let's say they just have like a complement of comorbidities, right? If the physicians determine that any of these conditions are likely to have an impact on their 6-month life expectancy, so contribute to the likelihood that they'll pass in 6 months, they would be considered related and we would cover them. Anything that's not considered to have an impact on the patient's overall life expectancy, we won't cover. So things we typically don't cover are like statins and thyroid medication. And because, which isn't to say that the patient can't get them, they can, just they have to use their regular Part D Medicare or their secondary coverer to get them covered. We don't pay for them. So they can still buy things over the counter. They can still get things from their regular insurer. But if it's not related to hospice, the agency is not the payer. So just to make that clear. A lot of people think they have to give up their care team and stop taking all of their medicines and get ready to die. And that's not sort of how it works. You can still see your primary care physician. In fact, we encourage that you continue to see your primary care physician. You just can't seek curative treatment. And, that could always be revisited. And then the other thing that's probably worth mentioning is that hospice is not a one-way street, right? Folks can change their mind and do. Sometimes they get better on hospice because of the increased services and sort of proactive approach that we take to management. And so they graduate from hospice. And then they have a period where they continue at a plateau until they experience another decline. And that does happen, especially for our folks that come on with like protein calorie malnutrition. they seem to do better with a little bit more attention, and maybe a deeper dive into the cause of their weight loss, which may be potentially reversible in the short term. So we do have a fair number of patients, but hospice as a benefit is infinite. As long as they continue to qualify and show signs of active decline, and they're pretty modest, they're pretty lenient. Some of our patients stay on hospice for years, especially our patients with dementia diagnosis. They can stay on for 2-3 years. The benefit periods are 90 days, 90 days. That's the 6 months, the initial 6-month life expectancy. And then after that, it's every 60 days. And they have to be seen by a physician or a nurse practitioner at each recertification period. So they're being seen 5 or 6 times a year at a minimum by one of our clinicians to recertify them. Any other comments or questions? No. Okay. So we'll just do this. So approaching end of life. So there are distinct time categories that most people on the continuum of moving towards end of life experience. There are always outliers, and people always surprise me. I always leave room for somebody to do something I've never seen before. But with enough of these kind of exposures, you begin to see the patterns in end of life. And most people experience most of these things. So there are 4 basic time periods. There's the transitional period, and then there's the active dying period, which includes the early, middle, and late stages of actively dying. So if we look at the patient from a functional perspective, okay, we remove kind of the psychosocial and the spiritual and the existential, and we just kind of look at the physical functional changes. They usually start anywhere between 3 to 6 weeks before the patient begins the active dying process. And we call this transition. And sometimes transition is best seen in retrospect. Like you need a few weeks of it to realize that there's a pattern emerging here. The patient isn't as engaged with their intimate circle or their immediate environment, or even in the bigger world. They stop talking about current events. They don't want to go like if they're in a facility, they don't want to go to any of the activities. They stop wanting to get dressed. They stop asking a lot of questions. Like their level of engagement with the world just kind of drops. And they become less emotive sometimes. They express less emotion. And you usually see a decreased appetite or a decreased ability to take adequate amounts of food that's accompanied by weight loss. Just as a note, because many of our patients have such limited mobility or don't have access to a scale, we have a surrogate marker for weight loss called mid-arm circumference, which is measured with a tape measure on the inside of the bicep. And that's usually done at admission. And we kind of track it over time because it is a surrogate marker for loss of bulk or muscle mass that comes when a patient has a significant weight loss. Usually we see in this transitional period that patients' mobility decreases, their independent mobility. So they may go from, being steady on their feet, but slow, to furniture surfing, to needing a cane, to needing a walker. Sometimes it's more precipitous than this. Patients just stop getting out of bed. But for the most part, we do typically see a downward trajectory in people's independent mobility. And we see more sleeping and less communication. So less initiation of conversation, more difficulty maintaining conversation or informational exchange, more trouble answering questions. And again, the retrospectoscope is really good at identifying this. We're usually a couple weeks in when family will say and usually when families at this point ask prognostic questions like, how much longer do you think it's going to be? Or when do you think this is going to happen? Or should I call my family? It's because they've noticed some changes. And that's kind of an emotional question cloaked in cognitive clothing, right? Like it's, should I call my family to come is not usually a practical question so much as it is what's happening here. And the way that we handle that is we reflect it back to them and say, tell me what you're seeing. What's prompting this question? Have things been changing? And when the family does that, or the caregiver does that, that gives us an opportunity to start sharing information about preparing for moving towards the end of life and saying, you know, I've been seeing that too, and I've been wondering about it. And if it's okay, I'd like to share some of the other things that we've been observing that, you know, give us a sense of what's happening. And that's sort of the segue. And part of the phrasing there is a desire, again, for that kind of flat hierarchy, that mutual explorer stance in which we can hand the ball of control back to the family member. Again, we're not the givers of knowledge here. Like, do you want to hear about this? Are you ready to talk about it? How much do you want to know? That's what's really kind of in that question and in that phrasing. So we say, is it okay if we talk about, you know, what I've been seeing, or I'd like to share, you know, more about my observation. Is that okay with you? And the family has the option to say no. Typically they don't, but at least in that kind of power exchange, they are recognized for their control over the situation, which I think is very useful. So that's a few weeks to a month before the death. In the days to weeks, so we're talking 7 to 21 days before the death, usually patients will exhibit more disorientation and confusion. They may be less oriented, like may not always remember where they are, or what year it is, or who you are. They use a lot of symbolic language. And for whatever reason, I'm not a particularly spiritual person. I'm not, my mother always says, you're not woo-woo. No, I'm not woo-woo. And I'm like I was steeped in like allopathic medicine, like a tea bag, you know, like I'm just mainstream all the way. But I've been doing this a long time. And this is a real phenomenon, and there's sort of no way to explain your way out of it. It just happens. People use transportation metaphors at end of life. They'll say things like, I've got to pack my suitcase. My sister's coming to get me. I got to get on the train. It's almost time for me to go. And I don't know what it is about these but I have seen it so much that I can't dismiss it. Has anybody else seen that or heard that? No? Oh, well, if you haven't, you might. I have multiple times. My sister's coming to get me. And they might have visual hallucinations, or what they call visions, especially of people who have passed before them. They might say, my sister came to see me, or you know, who are you talking to? I'm talking to my mom. Oh, tell her hi for me. You know, like we don't dissuade patients from these visions. We don't challenge them. We just say, you know, does it feel good to see them? It must feel so nice to be able to talk to them again. And often they're agitated, right? And this is actually, this is physiologic based. This is not always an emotional response. This is physiologic based. As patients' disease processes get worse, there's a lot of toxins that build up in the body from advanced cancer, from organ failure, like kidney failure or liver failure. And these can cause this type of physiologic agitation, or what we call akathisia, which is physical restlessness. So that's in like the 7 to 21 days before the patient dies. In the days up to 7 days before the death, you're going to start seeing more physiologic signs. You're going to start seeing changes in skin color. So in light-skinned individuals, they often look very pale. They may have a grayish kind of tint to their skin, or a colorlessness tint to their skin. Their hands and feet may start to get cold. Sometimes you can see poor capillary refill in their nail beds or their toenail beds. In dark-skinned individuals, they usually look ashy. They have like more of a grayish cast than a